Good morning, everyone, and welcome. I'm Dr. Asim Haseen, and I'm pleased to be here today to discuss an important topic in infectious emergencies. Today's presentation is titled Infectious Emergencies, specifically focusing on neutropenic sepsis. Over the next few minutes, we'll explore what neutropenic sepsis is, why it's critical, and how we can effectively manage it. Let's get started. Let's look at the question here. We have a 59-year-old man undergoing induction chemotherapy for AML, which already puts him at risk for neutropenia. He presents with a fever of 38.6 degrees C, and his neutrophil count is notably low at 0.3 times 10^9 per liter. Now, the key point is understanding what confirms neutropenic sepsis in this context. The options provided are various signs and lab findings. The critical thing to remember is that neutropenic sepsis isn't just about having a fever or low neutrophils alone, but it's about the combination that indicates a severe infection in someone with neutropenia. The most important concept here is that a very low neutrophil count, combined with fever, strongly suggests neutropenic sepsis. Among the options, the one that best confirms this is option C, neutrophils less than 0.5 times 10^9 per liter with fever. This combination is a classic indicator of neutropenic sepsis, which requires urgent recognition and management. So, in this case, option C is the key finding that confirms neutropenic sepsis. Let's take a closer look at the correct answer, which is C when we talk about neutropenic sepsis. The key points are quite specific. First, it involves a fever of 38 degrees C or higher. That's a clear sign that the body is responding to an infection. But importantly, in neutropenic sepsis, the neutrophil count is critically low, less than 0.5 times 10 to the 9th per liter, or it is expected to fall to that level soon. This low neutrophil count means the body's main defense against infection is compromised. So, when you see a patient with a fever and a low neutrophil count, you need to think about neutropenic sepsis. Recognizing this quickly is vital because it requires prompt treatment. This slide emphasizes the importance of understanding these specific criteria to identify and manage this serious condition effectively, aligning with our overall focus on early detection and intervention. So, when it comes to starting IV antibiotics for a patient with suspected neutropenic sepsis, timing is absolutely critical. The key point here is that antibiotics should be initiated as soon as possible, ideally within the first hour of presentation. This rapid response is essential because neutropenic sepsis can escalate quickly, and delaying treatment can have serious consequences. Looking at the options, the best answer is D, within 1 hour. This aligns with current guidelines emphasizing the importance of early intervention to improve outcomes. Waiting longer, even a few hours, could significantly worsen the patient's prognosis. Remember, the goal is to start antibiotics promptly, even before the full workup, because early treatment is linked to better survival rates. So, in practice, once you suspect neutropenic sepsis, don't delay. Initiate IV antibiotics immediately, ideally within that crucial first hour. Correct answer is D, as you can see here. This is a prime example of a time-critical emergency. When dealing with infections like this, administering antibiotics within the first hour is crucial. Why? Because every minute counts in reducing the risk of mortality. Prompt treatment can significantly improve patient outcomes. So remember, in these urgent situations, swift action with antibiotics is key to saving lives and improving the overall prognosis. All right, let's talk about choosing the best initial empiric IV antibiotic in cases of neutropenic sepsis. When a patient presents with neutropenia and signs of sepsis, it's crucial to start broad-spectrum antibiotics promptly. The goal here is to cover the most likely pathogens, especially gram-negative bacteria, which can cause rapid deterioration. Now, looking at our options, ceftriaxone is a good antibiotic for many infections, but it doesn't cover Pseudomonas well, which is a common concern in neutropenic patients. Piperacillin tazobactam, on the other hand, offers broad coverage, including Pseudomonas and anaerobes, making it a strong candidate for initial empiric therapy. Amoxicillin clavulanate is generally more suited for community-acquired infections and not aggressive enough for neutropenic sepsis. Vancomycin alone is primarily targeting gram-positive organisms, like MRSA, but doesn't provide the broad coverage needed initially. Finally, meropenem combined with linezolid routinely offers very broad coverage, including resistant organisms, but might be reserved for more severe or resistant cases due to concerns about overuse and antimicrobial stewardship. So, connecting this to our overall theme, timely and appropriate initial therapy is vital to improving outcomes in neutropenic sepsis. The most appropriate initial empiric IV antibiotic, considering coverage and practicality, is piperacillin tazobactam. It strikes a good balance between broad coverage and stewardship, making it the best choice in most cases. All right, let's take a closer look at the correct answer, which is B, as you can see, piperacillin. Tazobactam offers broad coverage against gram-negative bacteria, including Pseudomonas. It's also effective against gram-positive bacteria. This makes it a versatile option when dealing with serious infections where you need a wide spectrum of activity. The key point here is that this combination provides both extended gram-negative coverage and reliable gram-positive coverage, which is crucial in many clinical scenarios. Connecting this to our overall theme, understanding the spectrum of activity helps us choose the most appropriate antibiotic to effectively target the pathogens involved, ensuring better patient outcomes. Let's take a look at this question about when to add vancomycin in our neutropenic patients. The question asks, which situation most strongly indicates the need for vancomycin? Now, the options cover different clinical scenarios. First, fever alone. This is common in neutropenic patients, but fever alone doesn't necessarily mean we need vancomycin right away. It could be due to a variety of causes, including viral or non-infectious issues. Next, neutrophils less than 0.1 times 10 to the 9th per liter. That indicates severe neutropenia. But again, by itself, it doesn't necessarily justify adding vancomycin unless there are other signs of infection. Third, a suspected line-related infection or skin and soft tissue infection. This is important because infections related to central lines or soft tissues can be caused by resistant organisms, including MRSA, which vancomycin covers effectively. Fourth, chemotherapy-induced mucositis. While mucositis can predispose to infection, it's more about barrier disruption, but it doesn't necessarily mean we should add vancomycin unless there are signs of a specific bacterial infection. Finally, all neutropenic patients. Not every neutropenic patient requires vancomycin. We need to target therapy based on clinical suspicion. So the key point here is that vancomycin is most strongly indicated when we suspect a line-related or skin soft tissue infection. This is where resistant gram-positive bacteria are often involved. Therefore, the best answer is C, suspected line-related or skin soft tissue infection, because it points to situations where empiric coverage with vancomycin can be justified. Understanding these nuances helps us optimize antibiotic use, balancing effective treatment with antimicrobial stewardship. Let's take a closer look at why the correct answer here is C, vancomycin is added in specific situations, mainly when there's a suspicion of a catheter infection, which is a common concern in hospitalized patients. It's also considered when there's a risk of MRSA, the methicillin-resistant Staphylococcus aureus, which requires targeted therapy. Additionally, vancomycin may be necessary in cases of severe mucositis, where the mucous membranes are inflamed and vulnerable to infection, or if the patient is experiencing hypotension, indicating a more severe systemic response. Understanding these key indications helps us make more informed decisions about when to incorporate vancomycin into treatment plans. It ties into the overall theme of tailoring antimicrobial therapy to the patient's specific clinical situation, ensuring effective and appropriate care. Now, let's take a look at this question about neutropenic sepsis and what features really mandate ICU admission. We're given several options, so I want to walk through each briefly. Option A is a fever greater than 39 degrees Celsius. That's certainly concerning, but fever alone doesn't necessarily mean ICU admission is required. It indicates infection, but we need to look for signs of more severe instability. Option B is platelets less than 50 times 10 to the 9th per liter. Thrombocytopenia can be serious, especially if bleeding occurs, but again, on its own, it might not always mandate ICU-level care unless there's active bleeding or other complications. Option C, hypotension after fluids, is a critical point. Persistent or worsening hypotension despite fluid resuscitation indicates that the patient is not responding to initial management and may be in shock. That's a clear sign that ICU admission is necessary for closer monitoring and more aggressive support. Option D is an absolute neutrophil count of 0.2. While this signifies profound neutropenia, it doesn't automatically require ICU care unless there are other signs of deterioration. Option E, elevated CRP, suggests inflammation or infection, but again, it's a marker rather than a direct indication for ICU admission. So, connecting all this, the most definitive feature that clearly mandates ICU admission in this scenario is persistent hypotension after fluids. It shows that the patient is in shock and needs intensive monitoring and support. Recognizing these signs early is crucial in managing neutropenic sepsis effectively. The correct answer here is C now. Let's delve into why that's the case. When a patient develops septic shock or experiences organ failure, the priority is always to get them into intensive care. This is true regardless of their neutrophil count. So, even if the neutrophil levels are not particularly low, the presence of septic shock or organ failure warrants ICU care. The key takeaway is that the severity of the clinical condition, specifically septic shock or organ failure, trumps other factors like neutrophil count when deciding on the level of care needed. This highlights the importance of focusing on the patient's overall clinical picture to guide management decisions effectively. Let's take a closer look at what defines neutropenic sepsis. First, a key indicator is a fever of 38 degrees Celsius or higher. This is significant because fever often signals an infection, but in neutropenic patients, the usual signs might be muted. Next, we consider the neutrophil count. When neutrophils drop below 0.5 x 10 to the 9th per liter, or if we expect them to fall soon, that's a red flag. Neutrophils are our body's primary defense against bacterial infections, so a low count means the immune response is compromised. Putting these together, neutropenic sepsis refers to the presence of a fever in a patient whose neutrophil count is critically low. This combination is particularly dangerous because the infection can progress rapidly, and the typical signs of inflammation might not be apparent. Throughout this presentation, we've emphasized how crucial it is to recognize these signs early for prompt intervention. Identifying neutropenic sepsis swiftly can make a significant difference in patient outcomes. Let's take a closer look at the common pathogens involved in neutropenic sepsis. First, we have gram-negative bacilli, such as E. coli and Pseudomonas. These bacteria are particularly concerning because they can cause rapid and severe infections in neutropenic patients. Next are gram-positive cocci, which are often associated with catheter-related infections. These bacteria tend to adhere to medical devices, making infections more challenging to treat. We also see fungi, especially in cases of prolonged neutropenia. Fungal infections can be deeply invasive and are a significant concern in patients with extended immune suppression. Understanding these pathogens is crucial because it guides our empirical treatment approach in neutropenic sepsis. Recognizing the typical organisms helps us select the right antibiotics early on, which can be life-saving. So, in summary, being aware of these common pathogens, gram-negative bacilli, gram-positive cocci, and fungi, is fundamental in managing and improving outcomes for neutropenic patients. When managing suspected sepsis, it's critical to act immediately as if it's a septic emergency. The first step is to take blood cultures, 2 sets, without delaying the start of antibiotics. This helps to identify the causative organism later on. At the same time, You should administer IV antibiotics within 1 hour to start fighting the infection promptly. The first-line choice is usually piperacillin, tazobactam, which covers a broad range of bacteria. If the patient remains unstable or doesn't respond to initial treatment, you need to escalate the therapy accordingly. Now, when it comes to neutropenic sepsis, the urgency is even higher. Patients with neutropenia are particularly vulnerable, so rapid recognition and aggressive management are essential to improve outcomes. Throughout this process, remember the key message: swift, decisive action can be life-saving. Now, let's look at some of the key indications for ICU admission. First, septic shock is a major reason. When a patient develops sepsis that leads to significant hypotension and organ dysfunction despite fluid resuscitation, they need intensive care. Respiratory failure is another critical indication, especially if the patient can't maintain adequate oxygenation or ventilation on their own. Then there's AKI, or acute kidney injury, which can progress rapidly and require close monitoring and interventions that are best provided in the ICU. Multi-organ dysfunction is also a clear sign. When multiple organ systems are involved, the complexity of management increases substantially, making ICU care essential. Lastly, neutropenic sepsis, which occurs in immunocompromised patients like those undergoing chemotherapy, requires prompt and intensive management to prevent rapid deterioration. Overall, these indications highlight the importance of ICU in managing severe infections and organ failures, ensuring patients get the specialized care they need during critical moments. Let's talk about pearls for managing neutropenic sepsis. First, remember that fever may be the only sign indicating a serious infection, so even if the patient only has a fever, don't overlook it. Next, a normal CRP level does not rule out sepsis. It's important to understand that CRP can sometimes be misleading, so don't rely solely on it to exclude infection. We also need to emphasize not to wait for neutrophil counts to recover before taking action. Early intervention is crucial. Waiting can be dangerous and costly in terms of patient outcomes. This ties into our overall theme: early escalation of care saves lives. Recognizing these signs promptly and acting quickly makes all the difference in managing neutropenic sepsis effectively. Thank you so much for your time and attention today. I really appreciate you being here and engaging with the content. I hope that what we've discussed has given you valuable insights and practical ideas to take away. Remember, the key points we've covered are not just concepts, but tools you can apply to make a real difference. Connecting everything back to our overall theme, it's about leveraging knowledge and strategies to drive meaningful change. Again, thank you for your interest and participation. I look forward to seeing how you implement these ideas moving forward.